discussion for the Campaign for an All Ireland NHS. It's an online event and I'm delighted to be chairing it, even if you're all missing Alva Smith, who unfortunately is unwell, so I've stepped in at the last minute. I am hugely enthusiastic about this campaign, having worked in the health services both in Ireland and in the UK, and I can see the strength of having a enthusiastic nation committed to a national health service, as opposed to the divisive healthcare system in Ireland that confers an advantage to the more privileged in society at the expense of those who can't afford private healthcare. I would like to say that we have, for those who are new to the campaign, you're all very welcome, and delighted that you're listening tonight. We have a petition which you can access through the comments bar on the right-hand side of your screen. And in that you will find I think it's called the Campaign for an All Ireland National Health Service. Sign up to get involved on the ground. And then the second link is to sign the petition in support of an All Ireland NHS. Now, I think tonight's going to be a very interesting night. And in line with our ongoing education, and we're all being educated at the moment, and we're going to get great education tonight from our three discussants. We're going to talk about bringing health and social care into the public control, from whence we have to wrench it from both the divisiveness of private-public divide and from what our first speaker, presumably, I think, is going to talk about, which is also the legacy of it being controlled by the religious orders. So without further ado, I'd like to just give you a brief outline of the three speakers. Our first speaker is Peter Boylan, who is a retired obstetrician gynecologist. Our second speaker is Dr. Eléana Mhurchú, who's an intern in psychiatry. And our third speaker is Anne Ryan from Save St. Anne's campaign. So Peter Boylan is our first speaker. Everybody knows Peter. He's a household name following his high profile in our wonderfully successful campaign to repeal the Eighth. And since then, Peter has become a public advocate, perhaps one might even say a guardian, for the idea that our public health funds to be administered by the public and not by the traditional route of religious orders. So I'll switch over to you now, Peter, for your talk. Thanks very much.
Thanks, Veronica. Well, hi, everyone. I'm just going to talk about a few issues, really. And the first is what Bevan said in 1948 when he was setting up, introducing the National Health Service and starting it off in the UK. And there were three core principles, basically. One is that it meets the needs of everybody. Secondly, that it's free at the point of delivery. And third, that it's based on clinical need rather than the ability to pay. And that is the underlying core principle of a National Health Service. Now, as we know, the National Health Service is already operating in the north, and they also provide social services as well as the hospital and GP services. In the Republic, what we've been going down the road of doing is with Sláinte Care, which is government policy, and that's not going to change. So at the moment, and it's being slowly implemented bit by bit. At the moment, unfortunately, as we all know, COVID is dominating the health service at the expense of virtually everything else. And so that's a real problem at the moment and is undoubtedly going to delay things very significantly. Now, it's well recognized in Ireland, in the Republic, that we need about 2,000 more hospital beds. We need to beef up the ICU beds. We also need to beef up general practice. And there's a lot of problems with GPs retiring because of the age group. And they also need much more diagnostic facilities in the community, so that would kind of cut back on needing to send patients into hospital for tests, which could be done in the community and keep people out of hospital. One of the plans on this Launch of Care, of course, is to build 3 elective hospitals, which would do planned procedures like hip replacements and scheduled surgery in general, and investigations and so on. Now, they are, of course, expensive to build, as we know, but they'll also need a lot more doctors to work on them. At the moment, there's about 700 vacant positions at consultant level throughout the country. And if you look at the government website for consultant jobs, there are 19 jobs advertised at the moment. 5 of them, though, are either temporary or locum consultant jobs. And there are big problems, as we know, in getting doctors to come back and work here. One of the problems with the infrastructural deficits is that, for example, a surgeon will turn up on a Monday or Tuesday morning to do an operating list and discover that their beds are all occupied by people who have come in over the weekend or overnight through the emergency room. And a lot of these patients, newly admitted, will be elderly people who have had a stroke or fallen and broken their hip. And they are a difficult cohort to deal with. So that's why we need those elective hospitals to be built. And what's happening, particularly in orthopedics, is that a lot of consultants are getting completely disillusioned, and they're leaving the public service and going to work full-time in the private service, because they know that they can go into hospital in the morning and do the work that they're planning to do. But if we had these elective hospitals, then that would obviously address that issue, and we could keep them in the public service. So I've just got a short period of time. So we do have challenges with infrastructure, and as we know, the Children's Hospital, of course, has taken up a huge amount of money, which is becoming increasingly scarce because of COVID and the impact of that. We're short of staff, consultant level. So I'll just come on to the private hospitals now, and we have a long legacy issue in this country of the interplay between church and state, particularly in the provision of healthcare, also in education, of course, but I'll just focus on healthcare. Now, what has happened is that the Mater Hospital in Belfast, the Mater Hospital in Dublin, the Mercy Hospital in Cork, the entire Bon Secours private health service, and St. John of God's, all of which provide health services in this country under contract to the state. Some of them with a significant degree of private practice, for example, in the Bonds and St. John of God's. All of those that I've mentioned have been taken away from any possibility of state ownership, because they're now in what are known as public juridic persons, which is a vehicle of ownership when the religious are elderly and leaving healthcare, as they are in St. Vincent's, and they then transfer their assets and their organisation and their hospitals into the ownership of these PJP arrangements, which effectively are ultimately answerable to the Vatican. So the prospect of the state acquiring any of these hospitals is absolutely minimal and remote. And that is why I have been fighting so hard that the National Maternity Hospital should remain independent of ownership from any charity which has any association whatsoever, either with present or pre-existing Catholic organisations, because of the impact of Catholic teaching and ethos on women's reproductive health care. And we all know what I'm talking about there. Now, the original plan with the move of Holles Street to the Allen Park site was that the Sisters of Charity would own the hospital 100%. Now, that clearly was just an impossibility, although the board of Holles Street and a lot of other people signed up to it under the Mulvey Agreement. Now, that has changed a little bit in that the sisters are now trying to get out of healthcare, out of St. Vincent's, and put all their assets into a charity known as St. Vincent's Holdings. Now, St. Vincent's Holdings, the constitution has been lodged recently and has been registered with the company's registry office. But the core values of St. Vincent's Holdings are exactly the same as the core values of the Sisters of Charity running current St. Vincent's, which is effectively Catholic ethos. So again, the plan that the National Maternity Hospital should be owned by this charity is completely unacceptable, because it still has Catholic ethos written into it, although they don't call it Catholic ethos, but it's exactly the same. Now, the only way to avoid that is for the hospital not to be owned by the St. Vincent's Holdings, but to maintain its independence. And that basically is what I've been fighting for. And there are other elements of the constitution of St. Vincent's Holdings which are concerning. One of them is that they can mortgage any of their properties in order to build other facilities. And that's what St. Vincent's did a few years ago. They mortgaged the entire public hospital and took out loans from the Bank of Ireland. And the Bank of Ireland now has a lien over all current and future assets of St. Vincent's Hospital Group. So if the National Maternity Hospital becomes part of St. Vincent's Holdings, which will own St. Vincent's Hospital Group, then they will be able to mortgage the National Maternity Hospital in order to build a private facility. So that again is completely unacceptable. And the board structure of the holding company, which will own the National Maternity Hospital under current plans, is that only 2 directors are necessary for a quorum at any meeting. There can be a minimum of 3 directors and a maximum of 10. And these directors are people who will actually own St. Vincent's University Hospital, St. Michael's Hospital, the National Maternity Hospital, and St. Vincent's Private. So that's basically what's behind my drive to make sure that that doesn't happen. Now, there are, of course, other private hospitals in the country. There's the Beacon, and then there's the Blackrock Group, which is the Blackrock Clinic in Dublin, the clinic in Galway, and the Hermitage Clinic in Dublin. Now, Dennis O'Brien owns the Beacon Hospital, and Larry Goodman owns almost all of those other 3 hospitals. So good luck to anybody who wants to negotiate with them and get a good deal to put those hospitals into private ownership. So when you look at other countries, and you look at, say, France, which is supposed to have one of the best systems, and Germany, which is a very good system, they have a peculiar mix of where everybody has to take out insurance, which is sometimes paid by the employer, sometimes paid by the state, and in varying proportions. But the state then contracts with effectively private individuals, but there's also public hospitals. It's quite a complicated system, but it seemed to work extremely well for them. Where we're on the path of Sláinte Care, which is completely public. And there are, of course, practical difficulties coming down the road with Brexit and joining up with the North and us in the Republic. And then, of course, there's the influence of Westminster. So there are examples at the moment, though, of cooperation with the development of networks between the North and the Republic. For example, congenital heart disease in children is all performed in Our Lady's Hospital in Crumlin, including any children who have congenital heart disease and need surgery coming from the North. So that sort of cooperation could be, and networking can be expanded. There's great relationships between physicians north and south of the border, and most of us are members of the same colleges. I'm a fellow, for example, of the Royal College of Obstetricians in London, and a member of the Institute of Obstetricians and Gynecologists in Dublin. And most of our colleagues in the north are members of both colleges. So there's a lot of overlap, and there's a lot of communication between us all, a lot of goodwill in developing these networks. So I think the way forward is that we continue to develop those relationships, those clinical networks. Sláinte Care that gets developed so that eventually there's effectively no difference between the NHS and access to it in the north and the way Sláinte Care is introduced and developed a public health service in the south. And that leaves you then with the question of the ownership of the hospitals. So no new hospital built in this country should in any way be owned by a private charity when it's built with state funds. And if a private charity or the church or anybody wants to build a hospital, then that's fine. Let them go ahead and do it. And we live in a democracy, so people should obviously have the opportunity, if they want to, of taking out insurance but in no way should that be state funded, and the hospitals should not in any way be state funded. I know we had to take them over for COVID, but that's because of our infrastructural deficits, which need to be addressed, and there's a recognition of that. So I think that's about all that I want to say, really, about the whole thing. And effectively, in the long term, it's hard to see how we'll have a completely unified North and South, all Ireland National Health Service until the border is gone and we are a single country. But in the meantime, we can get to it so that effectively there's no difference between the two, and there can be interchange and interplay of patients from one to the other. Thanks very much, Veronica.
Thank you very much, Peter. And that talk has raised some interesting points, and people have made comments that I'll return to following the other two speakers. Our next speaker is Dr. Eléana Mhurchú, who's, as I said, she's just started practicing medicine and is currently an intern in psychiatry, I think. Is that correct, Eléana? I leave you introduce yourself, and you're very welcome indeed. Thank you.
Hello, my name is Dr. Eléana Mhurchú. I'm currently an intern in child and adolescent psychiatry inpatient. So I'm going to talk a bit about deinstitutionalization and the movement towards community-based care and away from Ireland's long history with institutionalization. Now, my intention is not to contradict the Save St. Mary's campaign, because of course we will need nursing home care going into the future. It's just that shouldn't be the main focus of care for the elderly, as it has been for a long time. And from the investigations after the massive amounts of deaths, 56% of COVID deaths in nursing homes, it has become apparent that the fragmented way in which the private and public nursing homes were integrated into the HSE played a large part in the weaknesses they had towards COVID outbreak and the lack of clinical oversight and governance. There is recommendations made by the Special Committee on the COVID-19 response that there is better integration between the private healthcare system and the HSE. But this kind of piecemeal privatization is pretty common across a lot of provision of services, not just for the elderly. Now, Ireland has a long and troublesome history with institutionalization, the Magdalen laundries, the asylum system, in industrial schools, but also in nursing homes and disability services. Now, I think it's important to define what we mean by an institution, because it also kind of elucidates some of the problems with these places. So institutions differ in size, but as per the UN Conventions on the Rights of People with Disabilities, they share common characteristics, such as isolation and segregation from community life, lack of control over day-to-day decisions, lack of choice of whom to live with, rigidity of routine, a paternalistic approach, viewing the patient as a passive recipient of care, and supervision of living arrangements. Now, a person can experience institutional life in a group home or even their own home if there aren't appropriate supports in place. And excuse me. So, and who is institutionalised in Ireland? Well, we have 24,000 people in nursing homes via the Fair Deal. We have, in terms of under 65s in nursing homes, we have 1,313 as of June 2018. And these have diseases. So the kind of things that people are there for include diseases of the nervous system like MS, acquired brain injuries, severe and enduring mental health difficulties, and stroke, and intellectual disability. And there just isn't anywhere else that we currently have that is equipped to meet their care needs, but clearly for young people, a nursing home is not appropriate at all. And in terms of people with an intellectual disability, as of February 2018, 8,400 were in residential settings. Now, and not to neglect the young population, there are 400 children in residential care as of November 2018, and kind of similar to the nursing home arrangement, where you have many private homes and some public provision of care or residential care for children who are in the care of the state. There's also a dual public and private system similar to that. So these are the people who are institutionalized in this country, and it's pretty obvious that from a point of view of autonomy, choice, as well as like improved outcomes, community-based care is preferable, and most people, say, especially elderly people, don't want to go into residential. They'd much rather remain in their own homes, or people with intellectual disabilities, you know, who cannot leave their parents' homes just because there isn't an appropriate housing for them. So what kind of supports do we need in order to allow people to live in the community? So the kind of supports that would be as part of a comprehensive community's social care system would be things like adult daycare services for you know, people with dementia, which provide respite, as well as a wide range of social and support services. Increased home help hours, which are when an assistant, say a healthcare assistant, goes to the house of someone with a disability or someone who's elderly in order to help them with the tasks of daily living. Increased healthcare package provision, that's when people with disabilities are cared for within their own home in a more intensive kind of way, and respite care. So say in the 2017 Planning for Health document, it was noted that 20% of those on the National Intellectual Disability Database, for example, have an identified need for respite. And of people with physical and sensory disabilities, there's a considerable demand for, and by that I mean, say, blind or deaf people, there's a considerable demand for therapeutic and personal support services, and 10% of those would also have an identifiable respite need. Now, respite care is not only for the individual, it's for the carers. There is a huge amount of work that's done in this country informally by family carers who are often quite decisive in whether or not someone is able to remain at home. And respite care reduces the kind of stress that's put on them by having to care for someone full time. And so, yeah, that's basically the kind of outline of what community care would look like. All of this would have to be directed in some respect by the primary care team, which is usually GP, multidisciplinary team, usually led by GP. As many people are aware, it's quite difficult to actually get a GP in this country at the moment, and there's huge pressure on services. And what services are available for what services are available for you often depends on your catchment area. I know it's quite frustrating for some parents with, say, children with autism, that in certain areas of Dublin they'd be able to access like speech and language therapies, and others they won't. Assessment assessment of needs and the delay in getting that is another big issue. So as you can see, we need a massive amount of funding. There are a lot of posts that remain unfilled, and you really have to wonder about why people aren't taking these jobs. And as well as that, there needs to be some kind of central, how do I say this, planning and direction, rather than this continued fragmentation and privatisation of healthcare that we seem to love in this country. I think that's pretty much everything I wanted to say. Leave questions below.
Thanks, Eléana, for that interesting observations of a young doctor on institutional care and improving community care in Ireland. Again, comments have come in, and I'll return to them following our last speaker, who's going to talk to a topic that's very current, as you will see from the background in from which she's been shot, save St. Mary's. So I'll switch over to her, and just to say to all the listeners that if you want to make a comment on what anybody has said or on what Anne is going to say, please click on the comments bar on the right hand side of your screen and write out the question, and I'll come to them when I'm chairing the panel discussion afterwards. Also there you'll find a link to signing up to join the campaign and to signing our petition. Okay, over and then. Thank you, Anne.
Thanks, Veronica. And great to hear the other two speakers. They're really, really interesting. So first of all, my name is Anne Ryan, and I'm the spokesperson for the Save St. Mary's Centre on Marion Road, that campaign. So I wanted to thank you for the opportunity to speak on this platform on crisis in care, and about the particular situation arising in St. Mary's Centre, Telford, because what we are witnessing firsthand the very human impact on human lives this crisis in care is having. And if the COVID pandemic does not shake up a very broken system and replace it with a more just and equitable one, I'm very concerned for all our futures. So I just want to fill people in, because this is a specific campaign, and in light of what the last speaker spoke about with regard to institutionalization, I think it's really important, and it's not something that I would endorse necessarily, the idea that these organizations should be maintained, and certainly not maintained in the manner that they have been run. St. Mary's, it was established in 1868. The first stone was turned in 1867, and it was set up through the funding, through a donation given by a Richard Martin's family to Monsignor Yore, and asked to specifically set up a care provision for blind and visually impaired people in the country. So this service was then handed over to the Sisters of Charity to provide that care and service. And initially it was a mixed service for both men and women, but they went on to specialise and care for the female blind. And they initially were in Dominic Street, in Lower Dominic Street. That's where they had their first organisation. However, with continued funding and fundraising and a donation, a very generous donation by the Dublin Lord Mayor at the time, of his horse and carriage, upon which they could auction it, they raised up to £2,000 at the time, and were able to purchase the former Marion Hotel on Marion Road, and that became the site of what is St. Mary's Centre, Telford now. So initially it was called the Asylum for the Blind, like you'll have heard the last speaker mention, and we conjure these ideas of what those kind of words mean and what those places were like. So it was an asylum for the blind. However, it was seen as quite progressive in some ways, because 2 years they set up the school in 1868, a school for the blind. Sorry, in 1864. Sorry, just have to check my notes there. Yeah, 1874. The school was set up for the blind. And 2 years after that, two nuns went to Paris and observed how Braille was taught in Paris, and brought back Braille teaching to the blind school on Marion Road, which is the first for that to happen in the country. So in some methods, they were progressive in their ideas of trying to provide an education, trying to provide a different life opportunity for those that had visual impairment and blindness. So I suppose what's happened is the school closed so it functioned as that. It functioned as a place, a repository for people with disabilities along the lines of blindness and visual impairment. So you will have a lot of people who were born blind or who developed blindness who would have ended up, if they were lucky in some cases, being accepted into St. Mary's Asylum for the Blind and School for the Blind. It did shut its doors in 2003. But as a result of that, a lot of residents who'd come to the centre when they were very young, there's some people there that were there from the age of 2, some people there from the age of 9, that were educated through there. So they never actually left the institution, which is exactly like what the previous speaker spoke about. So they remain there, a lot of them remain there on site. And because of this, St. Mary's had to develop another form of care provision, which was elderly care provision. And that was linked to what they would provide for the former pupils, but also they were able to open it up to the wider community surrounding it and open up elderly care for people with disabilities along that lines of visual impairment and blindness. So it straddles two sort of provisions of care of it, in an institutionalized setting. So its funding is funded through the HSC up to 80%. Large core funding comes from the disability section under the Health Act. And it's also avails of the nursing home supports fair deal system that the last speaker also spoke of. So what you have is an organisation under the auspices of the Sisters of Charity, run for a very long time by the Sisters of Charity and in receipt of public funding to provide those services. They did set up a company to take over as Peter mentioned, the number is dwindled, and as they get older, there is a move back away from them delivering that service and those care provisions directly themselves. So they've set up a number of companies in order to be able to continue that service. And they do so in the hospitals and they do so in the care systems, etc. And what we have happening at St. Mary's at this moment in time is that company with the board of directors have made the decision, the very timely decision, I think we'd have to note, in the middle of a pandemic, to wind up the organisation and petition for liquidation. So the Save St. Mary's campaign was born out of the announcement of the closure first, but then the arrival of the liquidators on site on the 24th of July. And it was set up by staff and ex-staff, volunteers, families, residents, relatives, and some members of the Disability Centre on site there themselves. I think it's really important to note that, on site at the time, it was a COVID-free run nursing home setting. And whether you agree with whether nursing home settings are the place for our elderly, for a lot of people, there is no choice in this country when certain situations arise in your home with regard to your loved one that you're not unable to provide that kind of care, and we don't have the support systems, as mentioned by the last speaker as well, within the community to be able to provide the adequate care and adequate support for carers to be able to look after their loved one in their homes. So we did have a number of residents remaining in the nursing home, 34. It has a capacity of 50 beds, and it also has a disability centre. It had 19 residents in the disability centre. The nursing home remained COVID-free throughout the pandemic, as in no resident contracted COVID during the pandemic, even though not adequate PPE was made available because of the shortages. And initially the slow delay in being able to deliver in testing held up things. Staff really were very dedicated, and because there's a lot of long-term staff that have worked there for a very, very long time. And they were very dedicated in their push to make, provide the best care possible for their residents. So we are now facing the possibility of liquidation. The campaign has set up. They have, but the provisional liquidators, Baker Tilly, are on site, and they have transferred most of the women from the nursing home section of St. Mary's, taking large risks with our elderly, which Stephen Donnelly has told us consistently is the sector of society we need to be most careful of when it comes to this pandemic. Yet Baker Tilly, a provisional liquidator, seems to be able to bypass those concerns and be able to continue to have moved residents out of the nursing home, this safe nursing home environment that they were living in, traumatized, very disorientated, family members very, very distressed, also very traumatized, because when the announcement was made, full COVID restrictions were in place. So the women on site, the very vulnerable, old, disabled women on site, many of them, were unable to actually engage with their loved ones to deal and process the information. They had to rely heavily on staff to provide that emotional support. The unknown situations of where they were going to move to, what it was going to be like. It was a very, very difficult situation for all involved, both the residents and their families and staff, to have to watch it. We've now 3 residents remaining on site in the nursing home. But the plans is that Baker Tilly, even after the last court date that we had in the High Court, where we were calling for a cessation of those actions of moving any more residents out, and a request for an examiner to be put into place, an interim examiner, we were that request was denied, and Baker Tilly were allowed to continue to move vulnerable women out of the nursing home. As they said, that these places might not come again, so they need to actually befit what happens to these women. If a place arises, they need to be able to access them, and if the families feel that that's the best move. The 18 women that live in the disability sector, I think, is a really important, and I know I'm overrunning time, but we're in the High Court tomorrow, so I really need to talk about these 18 phenomenal people that are living on site at St. Mary's in the disability centre. There's houses, assisted living houses and apartments on site. They were funded by the DCC in the building of them. So they were built purposely as social housing for women with blindness and visual impairments and other disabilities. There's 18 women still living there. They want to stay living there. They live in an environment which is constructed and built in order to be able to meet their needs of their disability. They, as I said, some of these are former pupils, so they're living there with other people that they've practically grown up with, that they are family, and therefore this is a very traumatic idea, that they would be separated from the people that they've grown up with, but also go to environments where they're unsure of where they're going, unsure of whether they're able to bring their guide dogs, unsure of what the environment, whether it'll be set up and suitable for people with their disabilities. So they're very, 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 very concerned, and very. I mean, it's been a very traumatic situation that's happening to them, and it's akin to, as one woman said, akin to a bereavement, a death, and akin to an eviction for some women. That's how they feel, that the sisters have disowned their responsibility and have allowed them. They haven't communicated with them directly, the Sisters of Charity, although they've stepped back and they're behind their DAC company that they set up. They are still the shareholders, they're still the landlords, as Peter has highlighted. Marion Road, this campus on Marion Road is adjacent to St. Vincent's Hospital. It's also adjacent to Caritas, which was also a step-down facility, which, as was spoken about, Peter, at the beginning of this meeting, he spoke about the number of beds that are needed. They closed. Sisters of Charity and their company and the board of directors on that company allowed a step-down facility to close in the middle of a pandemic. And they did so over a weekend when everyone was sent home because of a COVID outbreak. So staff didn't even have a chance to even fight or stand up for their jobs or the services that they provide. So what's happening at St. Mary's by the sisters and the DAC companies that they have put in place at St. Monica's, Caritas, St. Vincent's in Cork, because all of these organisations are being liquidated. And we luckily have been able to engage with the residents on site. We've been able to engage with the family members and gained great support from local communities like Ringsend and Irishtown, who've been fantastic at fundraising to cover the costs of our legal team. Our legal team is Gary Daly and company, and our senior counsels are Rory and John Kennedy, both, all doing a pro bono. We're just paying for staffing and court fees, etc. But so the campaign is getting great support. But what we're calling on is that if we're funded up to 80% by the HSE, if the sisters are still the shareholders and the landlords of this site, we actually feel that they shouldn't be the landlords of this site because it was gifted to them originally for the provision of services, particular services and care for these particular women that are still living there. So that the state should actually step in and ask the sisters to step aside and take over and fund St. Mary's, the nursing home and the disability centre, and fund it and maintain the facilities that are available there. And it should be publicly run. And that way, all of the other conversations that were had earlier by the second speaker can begin to be put in place with regard to the governance, with regard to the delivery of care, with regard to the choice, etc., etc. So yeah, that's what the campaign particularly, it's not necessarily standing up for institutions. It's not necessarily agreeing that that we should preserve them as is, but we certainly shouldn't be allowing the church or any organization of the church to maintain the properties that once provided these services when these women desperately need that property and those services themselves. So we do have a GoFundMe page. You can find that at the Save St. Mary's Marion Nursing Home Marion Facebook page. You'll find the GoFundMe page on that page. So we'd really ask people to donate because we're in the High Court tomorrow. Unfortunately, we're unable to attend in person because of the COVID restrictions. But I'd just like to say a big shout out to two major activists for the blind and visually impaired women on site who are residents of the Disability Centre, have worked tirelessly fighting for their rights inside the centre, liaising and communicating with Baker Tilly, a large international accountancy firm that deals with liquidations all the time. And they have been campaigning for the rights of blind and visually impaired women to the point that they have won, a link up, a video link up, video and audio link up to the High Court tomorrow, so that all of the residents may be in attendance to see all of the suits, all of the legal suits that are going to be there, the barristers, the solicitors of the Sisters of Charity, the HSE, Baker Tilly, stand in court and defend their decision to close St. Mary's. And they've also been able to be very active in regard to the way this is being communicated to them, because I think when we're talking about the paternalistic approach within institutions, absolutely, but these two women have fought against that and demanded that the communications that have been communicated with them, as in the instructions of what's happening to their lives and their future, had usually been delivered in letter form to blind and visually impaired women who would have relied on care staff maybe to read it out to them. They then had to process that and maintain it. These two women, Eleanor Burke and Claire Heffernan, who are listening in, they have managed to force Baker Tilly to have to spend some money and provide communications which better suit the needs of the residents on site. So it's now been delivered in emails and in audio, audible messages. So look, I've ran probably way over. I've probably said way too much, but yeah, thank you.
Thanks very much. And I think you covered a lot of ground there. And what you've said really covers what the two previous speakers touched on. There's a wealth of comments here and questions for the speakers. I thought what I'd do is give each of the speakers a few minutes to answer questions pertinent to their talks, and then maybe allow the three speakers to come in on more general questions. There are a few questions specifically for Peter. One is from a listener, viewer called Morna O'Hanlon. Hello, Morna. She would like to ask Peter if he has had any suggestions as to how to bring consultants to prioritise the importance of public health care for patients as opposed to private care for their own financial gain. This is a huge topic that really does merit a separate session, I think, and it goes to the heart of the public-private link, intertwining, the over-elaboration of the two systems with each other. But perhaps Peter could give us a few thoughts about that. And another specific question for Peter from Marnie Holborough is Sláinte Care quite as public as Peter suggests? One plank of Sláinte Care is the National Treatment Purchase Fund, which pays private hospitals to shorten public waiting lists. So I think I'll just go over to you, Peter, to answer those two questions.
I'll answer Morna's question first. It's a complicated issue, really, Morna. In my experience, working with consultants, they all, the vast majority, not all, obviously, there are some notable exceptions, but the vast majority fulfill their public commitments and more than fulfill them. We have a situation in the country whereby it seems to be almost government policy to encourage a substantial proportion of the population to take out private healthcare insurance. And the public hospitals, of course, as we all know, are very dependent on private health insurance income. No public hospital depends entirely on state funding. So there's a sort of a conflict inherent in the way that the public health service is funded, in that it does depend so much on private patients coming through. And what private patients do is they pay through their insurance. The insurance companies pay bed charges, which are about 1,000. They were a few years ago anyway, €1,000 a night. So that made up a huge proportion of the hospital income. And when we would discuss with the Department of Health, for example, or the HSE, what about funding for next year? They'd say, okay, for the sake of argument, it costs your hospital 100 million to run. We're going to give you 70 million. You're to earn the rest on private income. So that's the way the system works. So it's embedded in the system at the moment. Now, I talked about the infrastructural deficits, and orthopedic surgeons in particular have had huge difficulties in maintaining their skills in the public system because of inability to access operating theatre time. When they come in on a Monday morning and find their list is cancelled because the bed is taken up, all the beds are taken up by people who come in through the emergency room. So what are they to do? Sit around twiddling their thumbs, doing nothing? They can't get at public patients to treat them. They're not skilled, they're not trained. They're very skilled, but they're not trained, obviously, to look after people with stroke and so on. There's enough people doing that. So what has happened is that they've voted with their feet, and many of them have left the public service and gone and worked in the private sector. So the answer to getting consultants to work full-time in the public sector is to provide them with the facilities to do so and the ability to do so. There's nothing more disheartening than a highly trained doctor coming back from an international training program, a fellowship in a world-class institution, to be appointed a consultant in Dublin, to find that they've no secretary, they've no office, that they may not have even a space for a clinic, and if they're a surgeon, that they are scraping around looking for space in an operating list. So, you know, it's kind of a two-way street. And if the infrastructure isn't there, well, then the doctors can't do their work, and that's not really complicated. So we need more hospital beds, and we also need more consultants. Now, the other question was from Marnie. Is Sláinte Care quite as public as I said with the waiting list initiative? Yeah, I have a real problem with that, because what happens is that the state basically takes people off a waiting list, and supposing it's a hip replacement or a gynecological procedure. And what happens is that the patient will contact, or the GP will contact the National Treatment Purchase Fund, and they will be deemed eligible for treatment under that initiative. And they'll be told, you go to this hospital where Dr. X will do your operation. Now, they've never met Dr. X before, and Dr. X has never met them. Dr. X is working full-time in the private sector. So they turn up and they have their procedure and then they go home. Now, it's highly unsatisfactory from all sorts of levels. The money should be used to be invested in enhancing the public health service so that the doctors who are on whose waiting list these people are can actually get ahead and treat them. And also, there's a huge problem with continuity of care when somebody is taken from a public hospital waiting list, put into the private sector with a person they've never met before. And as I say, the doctor's never met them before. It's highly unsatisfactory. But I think what Sláintecare are trying to do in the meantime, until these new buildings and new doctors are appointed, is trying to help people by, what I think should happen is that those doctors who can't operate, for example, because their public hospital beds are occupied, they should be allowed to operate on their own patients in the private sector, but on the public purse, so that there's no financial gain to them. But they should be able to bring the residents with them, the trainees, and continue on working. It's a highly unsatisfactory system, but it's done with the best of intentions.
Just important to say that the argument about public health being financed by private health insurance needs to be looked at, I think, in the bigger context of if individuals were paying for public health care with an insurance policy similar to Europe, well then, in fact, we would be paying for our own public health care system. So, and I guess, the other point is that if we, just in counterposition to that for our listeners, I suppose, if we allow consultants to operate in private beds, well, are we not just encouraging more private healthcare? So I think these are things that we will have to tease out. But the basic point Peter is making is that it has in the public interest, and I think we're all completely with that. I would just like to read out one comment made by Jack O'Sullivan. He didn't ask a question, but I think the comment is worth reading out and drawing attention to. It's horrific that so many of our major hospitals, presumably Jack means private hospitals, are owned by a few ultra-wealthy men, some of whom have discredited backgrounds. And here I presume you're referring to Larry Goodman and Dennis O'Brien. And he says, while I agree that hospitals should not be owned by private charities, isn't it much worse that they are owned by these few wealthy and secretive individuals? Thank you, Peter Boylan, for shedding light on this situation. Okay, just moving on then to what Eléana was saying. Fran Horizon makes a comment. St. Mary's has assisted living accommodation for the visually impaired that allows them independent living whilst caring for them. So not every nursing home is the same. And I think Fran's comments are echoed by several different people who make the point that Anne subsequently made, that really, while there probably isn't much disagreement and there's been a general move towards deinstitutionalization of care, particularly in my discipline, in psychiatry, and a move to, that should be a strategically organized move to state-funded community care where that's possible. But other viewers have made the point that individual families, private families, cannot always give people the level of care that they require. So that sometimes some form of residential care is necessary, and this residential care does not have to be institutionalized. So perhaps, Eléana, you could just talk to people about the possibility of having residential care with maintenance of autonomy and choice.
Okay, so I'm unmuted. Well, first of all, I completely agree with you in that individuals who are elderly or who have disabilities should not be entirely reliant on their relatives, and that in itself can you know, open people up to abuse. In terms of supported care that isn't institutionalized, such as supporting living arrangements, like you're completely right in like not every centre is the same. I suppose you're trying to avoid the kind of, what is it called, the characteristics of an institution. So when you're supporting someone to say live in a group home or live in an assisted apartment, you're trying to make sure that they have choice over, you know, the activities they engage in. They have involvement in the community, and they do have some level of privacy and dignity and autonomy. And then in terms of, now, neoliberals like tend to use the language of deinstitutionalization quite inappropriately, and they will say, you know, we're moving to a community-based model of care, and they'll shut the residential care and then will not then redirect the money into the community. So the families are left stuck, and there is huge pressure on families, I think, especially in terms of like families of kids with disabilities who need round the clock care. Like there just really isn't enough respite. What was the second question? I don't know if I've answered both of them.
So I think covers it. I was asking a more general question. I was reflecting several comments that I won't read out individually, but I think there is a balance, as you said, between deinstitutionalization and autonomy-driven residential care. And now we'll thank you, Eléana, and now we'll come on to Anne. And there's lots of comments, Anne, not surprisingly, about your contribution. I suppose I think it's very important to acknowledge the contributions by Eleanor Martha Burke, who's a resident in St.Mary Centre, who says it's but an adult disability service with fantastic potential if allowed to develop and grow. And there are various other comments, like Alice Sheridan said, the actions of the Sisters of Charity highlight the absolute need for state provision for all health services. And there are lots of congratulatory comments to the campaign. I think not just for highlighting, not just for highlighting the injustice that has been done to the residents and the disgraceful manner in which the individuals were informed and the acute stress that it's caused for everybody involved, workers and residents and their families. But also because I think what you've done is you've really captured a lot of issues that are wrong, that Peter also touched on, that, you know, we need to own our public resources and we need to have governance of our public resources, and it should not be in religious hands or otherwise. So Breda Ryan puts this very well. She says, given that in 2018 St. Mary's received up to 8% of public money, is it not time that the state steps up and discontinues its reliance on religious orders to provide health and social care services? So this is a point that's coming through again and again, and you addressed that at the end of your talk. So I think maybe a few words on that would be a good way of beginning to conclude the meeting.
Yeah, I promise I'll try and be really quick. And I'm really glad, Veronica, that you brought up governance, and also Peter at the beginning of the meeting brought up governance. I think it's absolutely paramount that, and that's the problem, the governance that's been in existence over these organisations haven't been transparent. And particularly in St. Mary's case, we really need to look at the long-term connections with some of the board of directors and their governance of the organisation and their relationships to St. Vincent's Hospital, St. Vincent's Healthcare Group, potentially the new St. Vincent's holding charitable fund that the sisters got a dispensation from the Vatican to set up to gift their organisations to. I really think that there's certainly stuff there that needs to be looked at, but also in general in the governance of the organisations. I think the prior CEO of St. Mary's really did try to adapt. She was from a clinical background in psychiatric nursing, and she had a really good handle on really trying to progressively push where that organisation could have gone. Unfortunately, she was met consistently and continuously by the board of directors with resistance, and largely around the spending of funding, etc., etc. So yeah, governance really needs to be looked at when we talk about how our services are delivered, and particularly if we're talking about them going to be delivered publicly, what that governance will look like. So lastly, yeah, I mean, Eleanor says it all. It has incredible potential in St. Mary's, and she is that wonderful activist and a brilliant spokesperson for the residents on the inside of St. Mary's. So we are going to the High Court, and we're standing in the High Court. We won't be there physically tomorrow, but we are actually saying to them that, you know, corporate entities, so whether it's a charitable organisation that's running an organisation providing care or services, or whether it's a private run for the interest of profit, that it's not an entity like any other corporate entity where directors should be allowed to make a decision to wind it up and go to the court and petition it, and for the court to then grant that liquidation. So that's what we'd certainly say. And so yeah, if you could endorse the campaign, get in touch with us, show us your support. Tomorrow's High Court hearing is really important to us. The outcome of that, we're hoping for examinership. We're going to be calling for the HSE to endorse that examinership, with the possibility of them stepping in. And it would be one step in the process of what we've been talking on this meeting about taking something back. Care and services of our community, our elderly, our vulnerable, our disabled, etc. peoples should actually not be at the mercy of any corporate or charitable entities. It should be provided by the state. They are citizens, and I know most of the women in St. Mary's were voting citizens, and I know that they were visited by a member of Fianna Fáil, who went in and saw the services, thought the services were fantastic there, and the potential of the land to provide and continue to provide the services. So you're now in government, Mr. Jim O'Callaghan. So we'd like you to maybe speak with your colleague, Stephen Donnelly, and yeah, meet with the residents, talk about this possibility of taking it into state ownership and have it publicly run, where we can talk about developing proper integrated services for the residents on site. So thank you, Veronica.
Thank you very much, Anne. And that's a great shout out. And wish you the very best of luck tomorrow. And it's been very educational for me to listen to the background philosophy of your campaign, and I think we would fully endorse those sentiments. So thank you.
I'd like to thank the campaign for an All Ireland National Health Service, because they have been with us from the very beginning of our very first protest outside St. Mary's. And I'd also like to thank Peter for his own particular input and support to the campaign and guidance as well. So yeah, thank you.
Okay, thanks very much. Just to return, it's 8:10 now, so I thought I'd just throw out one question to the three speakers for 2 minutes, 2 minute response each. Okay, and it's from Tarn De Vere, and it's actually addressed to Peter, but I think it would apply to all of us, and it's something we need to think about. So I'm not asking really for an answer, I'm asking for everybody to think about it. Does Dr. Boylan think the will is there politically to ensure the National Maternity Hospital is in state hands?
Their turn is yes. I do think that the will is there politically, but in order to maintain them in their will, they may need a lot of pressure. And I think once people realize what the plan is, that the National Maternity Hospital will be handed over to an organisation which is a successor organisation of the Sisters of Charity, with a core values which are identical to the Sisters of Charity, that should raise alarm signals. But also the governance structure with the board structure and the fact that they, for example, you could end up packing the board with a lot of very conservative people. And really, I don't think that the public or politicians, once they realize what's happening, will stand for something that's going to cost probably more than 500 million. It's a wonderful design and it needs to be done and all the rest of it, but it needs to be done so the hospital is independent. I don't think that the public will stand for a maternity hospital looking after women's healthcare be handed over to a private organisation with no input from the state at all, and forget about leases on the land and all the stuff that will come out. Basically, it should be independent and not owned by St. Vincent's Holdings. 2 minutes.
Fantastic. So political will is public will. That would be lovely to think and to believe. And what have you got to say about that, Eléana?
So I wouldn't be as familiar, but I would echo that without public pressure, it's unlikely, well, it's very likely that they will take the easiest way out. And I think, you know, we have enough of a track record and a history to know that private charities or any kind of state influence in healthcare in Ireland should just not be acceptable, point blank, and that we really do need to keep the pressure on in order to avoid that here.
Okay, very much. And this is a subject, I guess, that's directly relevant to what you're saying. Is the political will there?
Yeah.
To separate church from?
Well, unlike Pete, I think with the present government, I actually don't think it's there. I think, like Eléana says, that unless political pressure is put on the government to step back from allowing the National Maternity Hospital to be built there under the system, under the arrangement that they've put in place now, I think it would be a really, really bad move for Irish women, considering everything that they fought for in the last decade or decades. So, but the political will comes from below, really, when you talk about what's happened with repeal, when you talk about how those things were achieved. So that needs to happen. You know, it can't be these conversations and these transactions that are hiding behind closed doors, which is what we've seen. And if a certain board of director, who was the former CEO of Vincent's Private and Vincent's Public, who had to step down and was called in front of the PAC, Public Accounts Commission, if he continues to sit on some of these boards, he is conservative, I would be very, very concerned. And he doesn't see it, he doesn't see any difficulty in liquidating Caritas, which was desperately needed for step-down beds. He's got no qualms about putting St. Mary's up for liquidation. So with people like that, on the governance end of the potential National Maternity Hospital, I think it's very worrying. So I don't think the political will is there just now, Peter, to be honest.
Well, it's up to the people to
exactly
make sure that it happens.
Well, not this government. That's where, unfortunately, they're silent. Those in power are silent.
Well, when it was announced that the Sisters of Charity were going to own it, and you remember there were all the demonstrations and over 100,000 people signed a petition, and that did, so public influence does work, and that's a democracy, and we live in a very functioning democracy, and I think our politicians actually, to be fair to them, do listen, and they do listen to input from people out and about and from citizens and people that they represent. So, yeah, I'm more optimistic than that.
Yeah, I think it's more this particular government, Peter, because we have been trying to talk to a number of members of that government, and it seems to be the silence has been deafening in the response to what's happening to women, disabled women, women with blindness and visual impairment, and all these men in suits are making these decisions about their lives, and the government have been silent.
That's not correct.
Okay, well, I think both your points are completely compatible with each other, and I think the way forward, which brings me back to our campaign, the way forward is to increase public awareness about these issues, and that's what we're about in the campaign for an All-Ireland National Health Service. Increasing awareness puts pressure on politicians. Look how quickly they changed on the amendment issue when they saw that it would lose them votes not to do so. And this hopefully will happen with healthcare system as well. I just want to read out one or two more comments that were made, and then I'm going to close. Just give me 1 second. Yeah, Bernard Mulvaney, I think, made a very good point about the progressive disabilities model of the HSE, to quote him, wishes to push on families. It's woefully underfunded and understaffed. The project is nothing more than a box ticking exercise. Again, the point that we made previously, that deinstitutionalization is a way of saving money, rather than being a way of bringing further dignity and autonomy to individuals. And Mike L. made a comment, which maybe you could put up for me on the screen. No. Oh, yes. Regarding home help, again, these are issues on the ground. He's aware that some older people are very mobile and able to fill their own personal care needs, but as they age, they need someone to help out with work, etc. So I think that's another point when we're building up public healthcare networks in the community. They need to be done in an organised fashion, and hopefully we're moving towards a situation where care, as much care as possible, can be provided in the person's place of choice, which is usually the home. So with that, I'm going to conclude the meeting. I'd like to thank Peter and Elaine and Anne for really fantastic contributions that covered a wealth of topics, and to refer everybody again to the two links, one to supporting our campaign for an All-Ireland National Health Service, and the other to sign and share our petition. So with that, Iwa, agus slán.
Thank you.
Thank you.